Welcome guys to another webinar. Today I am joined by Dr. Saad Hanan, one of our new counselors. So welcome, Dr. Hanan.
Thank you for having me.
How do you feel about this new position you're going into?
Oh, I'm very excited, very interested to meet all the new students. Yeah, I look forward to it. I look forward to working with, everyone that's out there.
Awesome. Yeah, I'm sure the students are also looking forward to some new fresh faces as well. So today we're going to talk about some wrist pain in pregnancy. Us outgoing counselors, myself, Dr. Chaudhry, Dr. Hickburn, and Dr. Kinslow, we're all very grateful to have had the opportunity to teach you guys over the last year. Now we're going to pass it off to Dr. Hanan and Dr. Nizamani, who you will see going forward. If you guys have any questions for us or about this presentation or St. James, you can always email us at usmle@mail.sgsm.org. So the question that was posed is a Gravida 2 Para 1 comes in for a routine prenatal visit at 35 weeks gestation. She feels the baby move often and is able to continue exercising, but she does experience that she has the inability to fit into her shoes. She also has pain and tingling in both of her hands, but mostly in her right hand at night. Physical exam shows fundal height consistent with 35-week gestation, but also edema of all of her extremities. Her range of motion is intact in both upper extremities, but she does have decreased sensation along her lateral 3.5 fingers in both hands. So the question here is, what is the most likely nerve affected in this patient? Is it A, axillary nerve, B, musculocutaneous nerve, C, radial nerve, D, median nerve, or E, ulnar nerve? So do you want to walk the students through kind of like how you would approach this question?
Definitely. So just by starting at this, looking at this question, there's a lot of information that is being provided. That could be of use, it could not be of use, because this is a very general anatomy question. And if, let's say, I got rid of the first 10 lines in this question, I'd still be able to answer it with just that final 2 marks. So I always, when I first look at a question, what I do is I read the question that's at the very bottom of the paragraph. So over here, I would straight away, as soon as I saw this question, I'll read the question. I'll be like, what is the most likely nerve affected in this patient? Just from that idea, I can go ahead and be like, okay, I know what they want. They want an anatomy-based question. They will probably provide me with some sort of a location, some sort of an area, some sort of a problem with the muscle weakness or something. If that kind of is my mentality well before I even read the vignette.
Of course.
So with that within mind, then I go into the vignette, and then I can just, cipher out some of the most important parts and kind of, leave out other areas. And if you look at it, they do talk about pregnancy and all of that, try to give that a little bit of background, but all you need is she has decreased sensation along the lateral 3.5 fingers in both hands. That gives you a very good understanding of what nerve is being affected. And then from there, you could, correlate with why she has it bilateral because of pregnancy, but that can give you a majority of the answer. So that's how I would address this one.
Yeah, and I would definitely approach it the same way. So some of the highlighted points here, again, looking at the last line, looking for what is the question asking. So nerve affected for sure. And then how does that patient present? So she has pain and tingling, both hands, but predominantly in right hand. And then again, that decreased sensation along the 3.5 fingers. So that definitely narrows it down to which nerve is it that is affected in this patient.
Perfect.
So the answer in this case is the median nerve.
Exactly.
Part of the brachial plexus. A lot of students get this idea that they have to be able to redraw the brachial plexus for their USMLE Step 1 exam or their MBMA exam. Is that something that you think students have to do?
See, the only time I personally started drawing the brachial plexus was the very first time I came across it, because I needed to, that was like the very first time I was introduced to it. So I needed a better idea in grasping the methodology of how it is formed and what goes about it. But afterwards, once I kind of drew it one time, I never went back to draw it. Because a lot of the times the questions don't really want to ask you, can you draw it out? They just want to know what area translates to what nerve. And so once you start to make a compartment for each area, location of a limb, you start to not need that whole complex
Yeah.
brachial plexus. You need to kind of correlate sensation and muscle movements, and they have their own compartments.
Mhm.
Once you understand that, it becomes very simple in knowing what nerve is being affected based off the loss of symptoms and sensation. So
Yeah.
that's how I would go about it. If there are people who are visual learners,
Mhm.
more than happy to say, definitely go ahead and draw. Because it depends, right? Some people like to visually learn, some people like to hear and they learn better sometimes. People like to do repetition. So whatever works, I
Mhm.
think that's the key. So I wouldn't say don't draw, but if you don't like drawing, definitely don't draw.
Yeah. The major point here is that you need to know which nerves are associated with what sensation
Mhm.
and also which muscle movements.
Very right.
So, in this case, the patient has developed a carpal tunnel syndrome as a result of the fluid retention from her pregnancy, which has led to compression of the median nerve.
Mhm.
Some other risk factors for carpal tunnel syndrome include diabetes mellitus, possibly rheumatoid arthritis, acromegaly, or chronic repetitive overuse. So a lot of people that are, typing all day,
Mhm.
they're
Yeah.
working with their hands.
That's like us now.
Yeah, you gotta get the support for your wrist. The median nerve provides sensory innervation to the palmar and dorsal aspects of the lateral 3.5 fingers, as well as the thenar eminence. And we know that that was the distribution that she was having paresthesias in.
Perfect.
So the other options, the axillary nerve, you could have injury to that from humeral neck fractures, shoulder dislocations, or a scapular fracture. But this nerve is responsible for sensation to the lateral shoulder, the deltoid and teres minor muscles, and involved in shoulder abduction,
Mhm.
none of which was present in this
Mhm.
patient. The musculocutaneous nerve, that would be affected if there was upper trunk compression, and that nerve is responsible for sensation of the lateral
Mhm.
forearm and also elbow flexion.
Mhm.
Again, not in this
Not
patient.
part of this patient's.
And then the radial nerve, if you have an injury of the mid shaft of the humerus, or if there is pressure in the spiral groove of the humerus, you can have injuries there. And the radial nerve is responsible for elbow and wrist extension.
Mhm.
This patient has more of a sensation issue rather than a
Exactly.
motor issue. So again, that would not be the correct answer in this case. And the final answer option, the ulnar nerve, that can be affected if there's upper trunk compression, and that is responsible for sensation of the medial 1.5 fingers on the palmar, dorsal aspects, and also finger adduction. And again,
Yeah,
not
not the
presentation
one
of the patient.
Exactly. And just like how you said that, each nerve, each area has a specific loss of sensation,
Mhm.
specific loss of weakness. So those are the keys. And
Yeah.
the information that is right there, that's how it will come up.
Yeah.
It won't come up any way different. They cannot tell you this, this nerve does something different than
Yeah,
it's
because
very.
that is the function of
That's
the nerve.
exactly. So these are very good anatomy questions, because if you do them more often than not, all you have to do is remember spiral groove. Okay, I know that nerve.
Mhm.
This area, I know that nerve. That's
Mhm.
about it. Yeah.
Then a little bit more about carpal tunnel syndrome itself, some causes and risk factors. It's pretty common. I feel like most of us have probably
Yep.
gotten some wrist pain
Yes.
from typing our essays and always being on our computers and our phones, tablets, all the electronics. They definitely can contribute.
For sure.
Often occurs in women aged 30 to 50. Some risk factors, we talked a little bit about a couple of them. So rheumatoid arthritis or other wrist arthritis. If they have wrist arthritis, that can lead to carpal tunnel syndrome. Diabetes mellitus, hypothyroidism, acromegaly, where they have bony overgrowth, that can lead to compression, or amyloidosis. And in this case, the patient that we had in this vignette, it's pregnancy-induced edema that is causing their carpal tunnel.
Exactly. Yeah.
But also activities or jobs that require repetitive flexion or extension of the wrist, but often the cases are idiopathic. So how would we diagnose someone with carpal tunnel syndrome?
Well, if I see somebody in a clinical setting that comes and tells me that the symptoms that they describe are more often enough based on the history that they provide, they'll tell you straight away there's pain or a little bit of loss of sensation. But the main thing they will always say is that as the day progresses, they have more pain or they have some sort of weakness specifically to the hand. And sometimes it might be difficult, but they can very well narrow down to the digits that are being involved. And just from that, you can get an idea of exactly where you may be going. There's also some other tests you could do apart from just having the history. You could do the Flynn and the Flynn sign, and I believe the other one, what is the other one
So
called?
there's Tonell and Valence, which we'll get into a little bit.
Perfect. So though you can always do those
Yeah.
tests. So you get a lot from the history, which is very important. And obviously you could get some from doing some diagnostic testing. Now,
course.
other things that can provide you with a little bit of help is, again, comes back to the history where a patient tells you what they do and
Yeah.
where they are at, right? They're doing some repetitive work with their hands. Well, you can, that can give you a clue. So a lot of it comes from the history, and you can use some diagnostic testing to support your diagnosis.
So for sure, like the most likely diagnostic approach is going to be clinical through their physical exam. So like you mentioned, pain of the hand and the wrist, tingling and numbness in the median nerve distribution. Sometimes they'll say that when they shake their hands, that will restore some of the sensation. So if you're a visual person, like I'm a visual learner, I like to utilize graphs and images, diagrams as much as I possibly can. You can see here in like I want to say like a chartreuse green color, you can see the distribution of the median nerve, which comes from the cervical area, C5 through 8. So along the palmar area, those 3.5 lateral fingers, and also like part of the volar surface area as well.
Yes.
So I would say, like, anatomy, one of those nice things is that you can utilize your own body to really understand what's going on.
Exactly.
So with the brachial plexus, you can see like how your fingers move. There's muscles in your arm and your forearm, and you can like, draw on yourself.
And
use your body as something to guide you.
As funny as it sounds, whenever I'm reading a vignette, and I see like, the abduction of the right shoulder is limited, and I'm sitting there and I'm like, as I'm thinking, I'm like, right shoulder, that muscle is connected to this, and that's okay, must be this nerve right here. And that helps.
It does.
Believe me, even when sitting there, it's just trying to, because you got to orient yourself. And sometimes even that provides you with an answer. So anatomy is much of, one of the best things is you have your own body to kind of test the anatomy. So yes, definitely anatomy.
So some of the maneuvers that you mentioned earlier, Tonell sign, when you tap the volar surface of the wrist, that will reproduce the paresthesias, or the Phelan sign, where wrist flexion will reproduce the paresthesias. If the diagnostic that in the clinic, if the diagnosis is unclear, you can always do nerve conduction studies. Or if the patient does not improve with your conservative management, there may be something underlying that's a little bit more serious, more concerning. So you can always do a nerve conduction study to determine what the underlying cause is. Again, I'm a visual learner. So if there's ever a time where you see like there's a sign or a maneuver or some kind of diagnostic test that is unfamiliar, look it up. Look at a diagram or find a video or some sort of descriptor that will help you to really understand what's going on. So Tonell sign here, you can see that they tap on the wrist and that will produce paresthesias. Phelan sign, you have the patient just flex their wrist and that will also produce pain.
Exactly. Both of those are fantastic if you ever want to practice them on your own. Someone who may have carpal tunnel, try that. You'll see it. There's also another test that I know of where you get the two hands out. But what you're trying to test is that if a median nerve is being compressed, it often loses the sensory when it comes to, let's say, the musculoskeletal part. So if you have your hands out like this, if you have your hands out, right, and let's say you have carpal tunnel on your right hand, if I were to go like this and then say, make sure that I don't try to resist me, all right, this hand will actually come inside if it has carpal tunnel. And the reason why is because when I give it its sensory, it overrides the muscle motor because it's been compressed. So that's another thing. If you want to try, you can do it in the clinical setting.
That's interesting. I didn't know about that one. Learn something new every day.
That's medicine.
So the nerve conduction studies, that would be if you were unclear of what the diagnosis is, or again, like if you try nerve conservative management and the patient does not improve, you have to always do further testing to make sure you're not missing anything serious. And then some treatment options. Conservative management always first.
Yeah.
So you can try splinting, where you give the patient lightweight neutral wrist splints, especially at night, where their symptoms tend to get worse.
Mhm.
Mild analgesics like acetaminophen and NSAIDs.
Mhm.
You can do some ergonomic corrections, so changing the position of computer keyboards, utilizing a rest pad. I have one on my desk because I get wrist pain when I'm typing a lot.
Yeah, yeah.
And then if they do have an underlying condition like diabetes or rheumatoid arthritis, you also want to treat that. That will also help alleviate some of the symptoms.
Mhm.
Then if conservative management doesn't work for your patient, corticosteroid or anesthetic injections can be an option. And in severe cases, surgical decompression, but those tend to be further down the line. You're always going to
Correct.
try conservative management
Exactly.
first.
And a lot of times the conservative management works for patients because more often than not, it's because of their day-to-day habits,
Mhm.
which are causing these problems, which is why we say idiopathic is one of the bigger
Yeah.
ones. And so repetitive motions or this are the reasoning behind them getting carpal tunnel. But if you get them to correct that, it often works out. But in cases like pregnancy or rheumatoid, well, it's not their day-to-day activity. Now it's something that else is causing the
Yeah.
problem, or should I say, narrowing the gap within the compartment. So if that is the case, you could definitely address, like you said, the main disease and try to get them back in order. But those are kind of those extras we can understand, right? Carpal tunnel you treat as you would for almost all of them. And then if you got to branch out, then you got to go further down.
Yep.
Yeah.
So some of our references here. Thank you so much for joining us today. If you guys have any questions, please feel free to reach out at usmle@mail.sgsm.org. To view some of our other videos, please follow us on our YouTube channel. We are also on Instagram. We post the questions on there. You can also find us on LinkedIn.
Mhm.
So follow us on our social media channels to keep up with the newest updates.
Yes.